ladies and gentlemen, thank you for your patient listening. With this, we come to our fourth, last but not the least speaker of today's evening. Dr. Jamshed Ahmed is a senior public health professional and epidemiologist having 20 years experience in disease surveillance and control programs in Punjab and Pakistan. He is currently holding the position of Head of Office, World Health Organization, Provincial Office in Punjab. He has contributed effectively in establishing dengue control program of Punjab disease surveillance system and shaping the VPD surveillance and response system in Punjab. He's the active member of World Health Emergencies team at WHO in the Emro region. And you all know that dengue is not only a medical problem, but dengue is a social problem as well. And I always say that unless and until we do not have an active community participation, we cannot control this disease. So Dr. Jamshed will be talking to you about out-of-hospital management of dengue, which is the strategic approaches for effective community engagement and intersectoral coordination for combating this menace. Dr. Jamshed, please.
My talk will be revolving around one of the important area that was part and parcel of 2011 epidemic as well as for the subsequent years. This was for effective community engagement and intersectoral coordination. I will not talk about what we did in the health sector or what hospital care or healthcare did during this epidemic and to fight for this epidemic in Pakistan. But what needed to be done and how we did it by engaging with the communities and other stakeholders. I will start. Intro of the dengue is enough. We all know what is it and how it is. Incidence of the disease is increasing up, and right now half of the world's population is at risk, and almost all the countries are now reporting different levels of epidemics, different magnitude of the disease. Still, we consider that dengue is grossly underreported. Asymptomatic infections are being neglected or not being reported through our regular surveillance systems. We all know about the vector. We all know about the two mosquitoes that are primary and secondary vectors for this disease. And also we know this vector is highly adaptive, and we need to work on control of these vectors inside our houses as well as around our neighborhood. We all know about this virus, 4 serotypes that are involved in the cause of this dengue. All these serotypes can spread the disease, and one serotype, once it is causing infection, it can prevent the lifetime immunity, but also poses a person to the threat of a fatal disease if it is infected by another serotype. All regions of WHO are now recording indigenous transmission of all dengue serotypes, and once the serotype is changed, the magnitude and the impact of the epidemic is severe. What are the drivers of increase in dengue? As you all know, demographic changes, population growth, unplanned urbanization, lack of civic facilities, land use pattern, as well as modern transportation, travel, trade, they are contributing to the spread of the disease. The disease is considered as neglected disease in the public health policy, least focus on vector control. Also, the skilled workforce is lacking both in vector control as well as in surveillance and clinical management. And on these areas, as you have listened from our previous speakers, we are working very hard on this to improve our skill set as well as workforce. Absence of cross-sectional approach was one of the factors that initially made us went into the panic and could not control the disease in early days, and also some deficient commitment which made the increase in dengue in different levels and different conditions, as Professor Waseem Akram and Captain Usman has shared with you. These are the contributing factors, and there are many more in the parts where these are most prevailing. Dengue in Pakistan, historically, it is a low burden country since 1961, when first time the virus was identified in Pakistan. There was no major outbreak, and by 2003, different cities they started reporting about the cases. Dr. Somia has given detail of these outbreaks. We have cases in Haripur, in KPK province, Kushab, Karachi. But in 2011, the Lahore experienced a major dengue outbreak that was associated with 21,685 confirmed cases and 375 deaths. And most of these deaths were due to dengue virus 2. This epidemic, as we have listened from Dr. Somia as well as Captain Usman, it was the worst ever that was reported by that time. Approximately 0.6 million suspected cases with almost 22,000 confirmed cases and 375 deaths, and in a very short span of time of 73 days. And this outbreak was beefing up day by day. As it was a new disease, clinical and epidemiological knowledge was limited, and resources to tackle this epidemic were deficient. We were deficient of skilled human resource as well as life-saving drugs. These were the common scenes that we witnessed during that epidemic. The hospitals were choked. People were rushing to the hospital. All the labs were choked, and the hospital beds were overoccupied. Even we were keeping 2 patients on a bed. And all the efforts were being focused on these vector control activities and unjustified fogging exercises that can pacify the concerns of the public and the politicians. So how Punjab government tackled the situation? That was the high level leadership that came to the forefront. Also invited from the countries, those who are having experience of fighting against dengue, WHO, Thailand, as Dr. Sri Lanka, and also Punjab government invited and gathered experts across the country with the relevant subject knowledge, whether these were vector control experts, the clinical management experts, as well as the epidemiologists, and also the public health experts. A high-level expert advisory group were formulated, and Dr. Somia is representing that dengue expert advisory group. Harness all government resources, as the government was fully committed at that time. So all the resources were available to fight against this epidemic. Then also private and volunteer capacities were incorporated in the system. The capacities built on emergency basis, training of the clinical staff, as well as the vector control staff, as well as the epidemiological staff for the surveillance and the case response. And we kept on learning from the experience. The pillars of dengue epidemic response in Punjab at that time were capacity building, targeted vector control, emergency capacity buildings, awareness to the public, and intersectoral approach. These were based upon the effective case management and also gathering knowledge and resources. Most of the focus was on clinical case management as well as vector control of human resource, finances, equipment, material to manage the patients as well as the vector, and also administrative machinery to engage with. But still, the outbreak was going on, and it was soon realized that to control this epidemic, we need to go beyond the hospital care. And it demands interventions beyond hospitals as well as engaging sectors other than health. So what were the approach that was adopted and that are now being refined over the years is we use digital technology to access and reach those who need to be involved in case response as well as dengue control activities, and also we share the roles and responsibilities with sectors and departments outside health. Community participation, as we all know, is a process whereby individuals, families, and communities are involved in local needs and priorities of the solution that can promote the self-reliance in respect of development, resource sharing can be made, and also a local goal setting and strategies can be adopted. And this can also promote equity by sharing the responsibilities. Approach that was adopted for this community mobilization, continuous interaction with the public at all levels. Level-specific interventions were designed and introduced, educating public on the roles expected from them and also making communities responsible for that role. Trust was established between the government machinery as well as among the public, and also addressing concerns and queries of the public. The actions were taken involving public at individual level as well as a household level, community level, and also different institutional levels. What has been done on the individual roles, updated knowledge on about the disease as well as the mode of transmission by providing right kind of information through right people, and invited them to act responsibly wherever she is, keep close contact with the local health system, and also engage with them so that they could not be engaged in believing in rumors and not be the part of spreading fictitious news. We invited them to follow preventive measures to protect themselves as well as their families, and also educated them to report to authorities if any suspected case of dengue is seen around them or in their families. And also we expected them and educated them to keep their environment clean. At household level, make people aware that Aedes likes to reside with them. Unjustified fogging in early days of epidemic pushed the vector inside the houses, so that household practices further help breeding these vectors inside the houses. So we need to educate them and educate on knowing the unknown, rather unnoticed, because vector was domesticated with them, but they were not aware of. And also we made them realize that they need to know their enemy, and the enemy was not the mosquito, but the practices by the people, how they are providing an enabling environment to the mosquito for breeding in their household. So we educated them on developing habits for in-house surveillance by themselves, and also intensifying effort to identify and minimize actual or potential larval breeding sites in and around them. They need to ensure household protection by using tight-fitting skins, wire mesh, and doors and windows. Also taking personal protective measures by wearing protective cloths, and also using repellents. Covering all water container in the house to prevent fresh egg laying by the vector. Also emptying drying water tanks, containers, coolers, birds, baths, pets, water bowls, plants, pots, and also other sources once in a week. And they need to regularly check the clogged gutters and flat roofs at their rooftops, and also granting access to field teams for surveillance and vector control actions inside their houses. Actions At the community level, they were engaged in formation of community groups to supplement and reinforce efforts at the household level, launching sport and local awareness campaigns, integrated community activities against the larva and adult mosquito, keeping the surroundings clean and improving basic sanitation measures, eliminating outdoor breeding sites, as well as cleaning weeds and tall grass to reduce available outdoor resting places for adult mosquito near their houses, mobilizing household to cooperate, thus involving community to crack the hard nuts who are not supporting in the surveillance and contact tracing. At institution level, weekly housekeeping activities in the institutes like hospitals, colleges, offices, and other workplaces, putting tight-fitting skin wire meshes so that vector could not come in, organizing regular awareness sessions with the employees and the visitors, and keeping the environment clean, and also notification of the cases to concerned health authorities for further investigation and case response. So what means were adopted to reach out the community, direct and regular interaction by the outreach teams and health experts, calls for the raising awareness, special campaigns through mass media, print, electronic, radio broadcasting, TV talks, also electronic media, TV ads were used, engaging local cable networks so that people can get the message in their local languages, use of social media, messages and testimonials by the celebrities and notables, religious, political, and also health education materials in local languages, including posters, pamphlets, handbills, and hoardings. These are some glimpses of the reaching out to the communities. You can see and interacting with the people in the roads, and also approaching to the household level, involving people in the vector surveillance in-house, using school students and madrasa students. You can see police constable engaging with the students to educate them, and using students, school students for the vector surveillance and dissemination of the messages, and also competitions for making posters and speeches at the colleges and other institutional levels. Digital technology was also used to break the barriers of communication. Dr. Somia has talked about that. These are the complete routing system supported by PATB, Punjab Healthline, which is a toll-free helpline, robocalls, mass SMSs, engaging with the GPs, and media education were the approaches that was used through this digital technology. This is the screenshot of electronic complaint routing system. People used to call and approach those links that were provided to them to lodge their complaints, and then the departmental system, they respond to those complaints, and thus a dashboard can present the situation, number of complaints, and the complaints that has been addressed and resolved. Captain Usman also has touched upon this health line, how this health line is being used over the years, and it was really helpful in also tracing all the complaints and feedback from the community. Such kind of education material was pictorial messages as well as messages in the local languages. But we felt that knowledge is not enough. The behavioral changes of the dengue prevention and control, despite growing knowledge and awareness, sometimes people do not act responsibly. Regretfully, even the educated individuals are not behaving responsibly in their respective communities. What was required then? Simply for law and legislation that was adopted, and Punjab Prevention and Control of Dengue Act was promulgated in 2011, and health inspectors were appointed to enforce the regulation under this act, as well as use other administrative authorities and tools to enforce control dengue. And under this act, all public and private sector health entities were made responsible to share the dengue related data, and also the violators were lodged FIR against them if they are not abiding by the SOPs, or larva and breeding sites are present in their found in their premises. So there are some features of this legislation. Now I will go to the cross-sectoral approach of this dengue control.
Dr. Jamshed, we have only 1 minute
yes,
for
please.
your presentation. We have only 1 minute because we need to have you. We have only 1 minute for your presentation. We need to take some questions too.
Okay, I will just finish. This was basically a setup that was made under the chairmanship of Chief Minister Punjab, and then all the departments were made responsible and given responsibilities and roles in dengue surveillance and control activities, as well as the vigilance. Captain Usman has talked about this Central Emergency Response Committee, and there was District Emergency Response Committee, as well as Tehsil level response committees, and then different departments other than health sectors were given responsibilities specific to their roles. And I have listed a few. Presentation is available. Like, for example, Education Department was given a role in health education and communication component, as well as it was engaged in inclusion of dengue prevention messages in the curriculum. Public Works Department was engaged in safe and dependable water supply, adequate sanitation, effective solid waste management, and also surveillance activities. So these are the examples where non-health sectors were response being taken by the health department. And this is the standard operating procedures that Captain Usman referred to. First version was developed in 2014, and then over the year, by the experience and by the role that department played, we came up with the revised version in 2020. And this is the app that was used by different departments and to report and to respond the different activities of dengue control. So these are the lessons learned, that communication and engagement with all stakeholders is the bedrock for dengue prevention. Government and public should work hand in hand to combat the epidemics. We need to win the trust of the communities, and also we need to improve basic sanitary measures and surrounding around us. Communities must take charge of their neighborhood, and also role of media is critical. So we need to be ready better than caught unprepared. So these are some of the lessons learned that we have learned during the case responding this epidemic, and these are the recommendations need for the social communication and health education unit at all levels, coordinated activities involving all the sectors, as well as developing specific and target specific messages with the uniformity, so that a clear message can be conveyed to the community, and pre-testing of the messages, campaign evaluation, and focus on elimination of the misconception. This was the lesson learned that we had during this COVID response as well. I finish here. Thank you.